questions, that is like highlighting the really big important stuff. So please, as you go along, again, this reflects back to preparing for your CMS for both AH2 and PHARM. Okay, let's get into some, let's see, where do I want to go with here? Let's do some documents. Yeah. So when you do these guys, keep it simple, right? Oh my God, please, not like your templates. If you spend all like your 2 o'clock, don't do it. Just fill in some basic stuff. And if there's nothing you can find, then put NA, whatever. You know, like somebody sent me an email I thought was brilliant. They said, you know, what was it? Oh, scope of practice. You do need to know scope of practice, like when you're intervening. Can LPNs assess? No, they can't. Can they teach? No. See? So there are certain things that the boards will require you, but don't really go down a rabbit hole. Say, I could not find it. Speaking of finding things, what textbooks are we going to be using? What do you think?
Yeah.
Done. Nutshell. Now, the only thing that I would recommend you do, use your text for, if you can't find what you're looking for in ATI, like Pathos week in ATI, which is fine. That is the big test you're going to be taking at the end. So that's where you want to get that information from. Just look it up there. If you can't find it, put in. Couldn't find it. And when I ask you a question, I couldn't find it. But the questions are more on the lines of the like side effects, MOAs, contraindications, indications, like why are you giving? You're at the bedside, right? You're getting ready to give something that could kill your patient. This is what is one of the quickest ways to kill a patient? Through pharmacologic agents, would y'all agree? By via which route? IV, right? So, and then omitting something. What did somebody say earlier? Oh yeah, not seeing, yeah, they're still nightmares. Like you have an assignment of 3 or 4 patients and you forget C1. That would not be a good day. And I'm hoping that patient is cognizant to put the light on, but if they're in critical care, you need to critically get off the unit and go do something else for a living. If you forgot to look at a patient, see where I'm going? Yeah, but it's still a fear. So yeah, this is pharmacology is one of the biggest, fastest ways you can actually harm or kill a patient. But PHARM is awesome. You may find yourself, okay, you've already had a PHARM class, which is 305. Risa, love her. It's chronic. You just came from the chronic. We're gonna do a Q, we're gonna do fun stuff. Like, if you don't give that adenosine and convert them to normal sinus rhythm, they're not gonna do well. They're not gonna perfuse. So yeah, that's going to be primarily this semester. Okay, I know I'm moving really fast, but I have a lot to cover with you guys. You know what? Preventing, one of the things I asked myself when I'm practicing, when I was practicing, I would say, okay, we have a problem, like in the ED, right? You have overdose. What is your first question that you ask yourself? Do we have an antidote? Do we have an antidote for this, right? Because what do antidotes do?
Keep you from that.
They reverse stuff. Like what? What are some of the things that you reverse? Yeah, naloxone. Huh? Oh yeah. Digitabs for digitalis. You know, toxicity. With dig toxicity, you see an overexpression of bradycardia, right? And then plus the other things, like the halos, that stuff won't kill them. It is the bradycardia, that overexpression of a negative chronotrope. I'm like, huh? We're gonna talk about that today. I think Risa went through that stuff, but we're gonna do it. You did a little bit of it? I knew we talked about it, and I'm going, yeah. And she did adrenergics too, right?
Yes.
Oh man, what a girl, love it. But antidotes, this is quick. Even if it's activated charcoal, even if you have to drop a tube, put some charcoal in there and deactivate whatever's in there, like acetaminophen, is one of the typical things that you'll give that. So yeah, I'm gonna have some antidotes on the test, throughout the semester, I think. We'll see. There's our mantra. Okay, let's get down to some just conceptual stuff. And then we'll, okay, this right here. This is a model that, I invented or created when I was doing my dissertation work at the VA hospital. I see a problem with the proper assessment. And I am sad to see that we've actually regressed on our assessments. You guys know what I'm talking about? Have you seen some of the nurses? What does their assessment look like when you go in there at acute care?
Nothing.
Nothing, exactly.
Hi, good morning. I'll see you in 30 minutes.
That's it, that's it. Oh, okay, go old school chick right here. I will still do a full head to toe in less than 3 minutes. Yeah, 3 minutes, you can do it in less than 3 minutes. You absolutely, like a physician, they go in, what do? They look at their art, if it's post-surgical, they're like, okay, looks good, it's not bleeding, it's not stinky, it's, you know, their white count's fine, and they're not hypovolemic, whatever. So they do this survey. You can do it head to toe. They're going, really? We take 15 to 30 minutes in the lab. How can we do a full head to toe? Well, you just get efficient, extremely efficient, because you have to be. If you're taking on a regular medical surgical unit 4 patients or 5, you can't be lollygagging around with your assessment. You've got to go, bam, right like that. And skin. Now that's a different thing, like on the back side, if you can turn them real quick, but that's not always feasible. You gotta look at their skin, so we don't own those to keep. See where I'm going? But it doesn't take, you know, a full 15 minutes or even 5 minutes to do a physical assessment. But do it. Don't go in there and, you know, not do it. Yeah, they go in there, they write their name on the board, they look all bored and everything. But they're back to the patient. My name's Susie. I'm an RN. I'm gonna be your nurse today. I will see you in a few minutes. Really. We're gonna talk about nursing decorum tomorrow. That's not the way you do that. No, you get out your ears, your eyes, you look, blah, blah, blah. It's when you do not do that's another way you kill a patient. Would y'all agree? If you do not do a proper assessment, you can kill your patient, I promise. This triad assessment applies to every area you work. Urgent care, labor and delivery, peds, ICU. It starts off with 3 things. Physical assessment. Do you have to assess your patient before you give a pill, a course? Even if it's a cold lace, you have to assess if it's appropriate to give. Of course. What if they're still going like this? Stooling. That means stooling. Sorry, they're like, what's that? What you doing? What is that? Yeah, they're stooling. Are you going to hold the cold lace? Yeah, that's a part of your physical assessment. How crucial are vital signs? It's non-negotiable, right? If you're a nursing tech, and I've worked under nursing techs that every single patient had a respiration rate of 20. Is that true? I know. I love that look. It's like, no, you are being fraudulent. You're being fraudulent and lazy. Did you listen for a minute? Of course you didn't. Did you feel that pulse for, right, whatever it is on the machine? Maybe it's through the machine, the robo-nurse or something. But vital signs it's a non-negotiable thing. This is another way how to kill your patient. They're quantified. Oh, and hence why they're going to the nurse model versus tech model. Does that make sense? Like techs are getting less and less things to do because there have been deaths related to improper vital signs being delivered to the nurse, right? So vital signs, labs, this is your nursing assessment. Physicians have a lot more, right? PAs, nurse practitioners, that some of you will be, will have a richer sort of assessment. This is why I developed this model. This is published, by the way. Labs. Why are labs exponentially important to know? Just like the other assessment findings. Physical assessment, vital signs, labs are all equally as important. Because if I don't fill in that part of the puzzle, I can have a dead patient by the end of my shift. That's not gonna happen. It's not gonna happen. Labs. Okay, let me get you involved now. What are some abnormal labs that you might find? Just name the lab. Oh, I love it, potassium, because potassium affects exactly. Oh, you know what, you guys, I'm bad at like missing the break. Oh, we're good. Okay, I really am. It's like you have to shut me up. I need to get a clock in here. Okay, yeah, that'll kill you. Cardiac arrest, especially hyperkalemia, right? What are some other things that could kill your patient if you do not acknowledge that lab? And yeah, all of the electrolytes, even calcium can affect the heart. How about hyponatremia or hyperkalemia? Exactly. Ooh, good. Seizures, neurologic. And again, that's going to be some of our content, big content today. Yeah, so you have to look at your lab and say, oh crap, I know what can happen if I have hypo or hyper, whatever it is. It's either usually going to be neurologic, muscular, cardiac, deep tendon reflux, but I think about what's going to kill them today, right? What are some other labs that could harm a patient? Huh? Oh, you know, she said white blood cells. Oh, yes. And what are we speaking of here that could kill your patient within a half hour?
Infection.
Leading to, oh, are we gonna do sepsis this semester? You know what, you guys are gonna know shock so well that you're gonna be able to teach it this semester. And in fact, we're gonna start talking about shock today. I have my document right there. Shock is what kills. Septic shock is one of the quick, well, you know, besides the cardiac arrest. That's cardiogenic, but sepsis, and especially if it is a gram-negative septicemia, half hour done. You guys are gonna know not only the process of, you're gonna know the patho, you know, involved with sepsis. It's called systemic inflammatory. Widespread vasodilation and capillary leak. You lose vascular volume and you're vasodilated. What happens to the blood pressure at that time? It tanks. Done. End of story. That's how they die. And if it's left untreated, that sustained hypotensive state will lead to what? Death related to what? Multi-organ dysfunction system. Organ failure. It's all about hypoperfusion, right? So yeah, labs, my white count. And with that white count, you can have high, greater than 12, and then less than 4 on the surge criteria, systemic. Oh yeah, you guys, and I'm gonna test y'all on that later on. I'll let you know when we do our exam reviews. Anyway, so physical labs, you could kill your patient if you don't have them. Now, part of the process, or the process of keeping your patient alive, even if they're in an urgent care center, they could die. That's why they go there. They're sick. You know, they don't want to go to the hospital, they go to urgent care. Or it's the quickest way there. And they want to save money on an ambulance, too. It's true, they do. You know. Surveillance, what's surveillance? Rounding. Okay, I know press, I know some people in here work at press. And we had a rounding schedule. But it always turned out to be very fraudulent. Again, well, the vital signs are often fraudulent. And the rounding schedule. That's 1 hour nursing me, computer on wheels. I'm right outside my patient's rooms, right there. I'm right there. I'm not up there at the desk, I'm talking about how great I look in my scrubs, and you know, I don't do that. I'm there for my patients. Advocation for patients, and I'm right there. And I'll tell them I have a spectral link, and we'll talk more about this tomorrow. But anyway, surveillance. It is the patient who you think is just perfectly fine, who suddenly has a ruptured aneurysm or a stroke, and now they're dead, right? See how long have I been a nurse? I have not let a patient die, not once, and certainly have never been a cause of a patient dying, not once. You know why? Because I'm terrified. I'm terrified. Last day of work, I'm still thinking, I could lose a patient today, you know? I'm never any complacency as a nurse, ever. So, yeah, so I was always this, you know, surveilling type of person. Oh, this is evidence-based by the way, these terms. Early recognition is the key that this whole thing is based on. Now, what does that mean to have an early recognition situation? Early recognition of the patient decline. Because the earlier you recognize it, the better outcome is gonna happen, because you're gonna have expedient intervention. It's this is not rocket science, really simple stuff. You just have to do it, and you have to do it every single day. It's the day that you're a little bit, you know, complacent, that you lose a patient. I've seen it. If you're in charge enough, you know, because you walk into a patient's room and they ain't breathing and they're blue. The last I heard is blue cyanosis is not a good human physiologic color. Would y'all agree? It's abnormal. Yep, they're dead or going on the way out. So I just know this is why I invented it. The labs were not being looked at, and through lack of surveillance and proper assessment, I would be then the person helping them transfer them to the critical care unit if I were not working there that day. You see where I'm going? So it became a huge, huge passion to prevent this kind of stuff. Then early recognition vigilance. What does vigilance mean? That when you recognize a decline in a patient, you stay with them. You don't drop the ball. Now, staying with the patient, did that mean you call the MET team or rapid response? Yeah. Get somebody in there. Now we have rapid response, and at press it's called MET, medical evaluation team, right? Kathy Davis got that implemented. I'm like, brilliant. I had to call them one day. Not that we can't assess them. You have maybe 3 or 4 different patients you're taking care of. When you have an emergent situation, that becomes your world, right? But what happens to those other patients that are okay, but they still need your help? You cannot leave them, so you call the MET team. Then they can evaluate them and send them off or keep them there. Oftentimes they stabilize them, we stabilize them. Ideally, you want to keep them on the unit. So the whole goal to giving PHARM, pharmacologic agents, or medical or whatever, medical surgical, is to prevent failure to rescue. These are all terms that I did not come up with. I just put it together. Really easy. So we'll talk about more about this in med-surg tomorrow. Y'all are gonna be new nurses, right? New nurses. You're gonna say, I know. I graduated from Brooklyn College and I have a baccalaureate. That's when you really need to be humble, because, and you might feel that you don't need to ask questions. Get a good preceptor. If you're not getting what you need from your preceptor, find a different one. I'm not kidding. If they're treating you like crap and they're not answering your questions, you need to find a better, I promise you. Do not settle. Do not settle for a crappy, certainly mean preceptor. It will not serve you well, and it will not serve your patients well. So, this is you, initially. You have graduated, you've done a great job, but when in doubt, check it out. There's another leg to this, not only asking questions, but how about intuition? How do you guys feel about intuition in nursing?
It's your children, it's the same thing, it's like being a mother, if you feel something's wrong, then you should address it.
100%. It's that feeling, that intrinsic thing that something is wrong. And you know what you do is you say something is most likely wrong. So what do? Grab a vital signs machine, take the blood pressure, take the pulse, get your blood on, make sure you look at the lab, do another physical assessment. Like somebody's stroking out or having a seizure. Neurologically, at 7:30 in the morning, I'm going, oh, they're fine. You know, they're alert and oriented to everything, you know, that you ask them. But then they're acting a little funny, and then you have to assess, did I give them a med that made them like an opioid, clearly? Respirations are gonna go down, you're getting sleepy, you know, so you have to use your critical thinking in the context, you know. But then, no, I'm not giving them anything. And then you go, something is wrong. Call the doctor and say, you know what, they're neurologically, do a Glasgow moment, and report your findings. And then they could do, I don't know, whatever. They might come see them, or if it's chest pain, you know. What if your patient, let me ask you this, what if the patient says, oh, I'm having some heartburn? What are you gonna do? Wait for them to burp or fart? No. Oh, she said PRN for heartburn. Yeah, might be. They might actually have a history of GERD, so that would behoove you to know that. You know what thing you do? Do you look to see other accompanying symptoms like diaphoresis? Ooh, what are you gonna do at that point if they're having each other in diaphoresis and other things that lead to, what are you thinking right now?
Heart attack.
Myocardial infarction. We don't call it heart attacks anymore. You guys have this like sophisticated language, so we call it like MI, right? Now what are you gonna do if you suspect an MI? EKG. Is it non-invasive? Nobody's gonna yell at you for getting an EKG, I promise you. I've never been yelled at for getting a stat EKG. I just do it. Call RT, usually RT, you know. And they come in, do a stat 12 lead. Let me tell you, you discover stuff like they're having an MI. I'm telling you. Now, if they go ahead and go up like that, then I'll say, you know what? I checked. I did my job. You see where I'm going? If you work at a place like Heart Hospital, now this is nothing against truck drivers, because I had family in Texas. You know, my buddies from Texas, and we had some truck driving people in our family. And did they have bad lifestyles? So at Heart, these truck drivers come through. And the reason I'm bringing up this demographic is because they have terrible. They eat the worst food, they don't have exercise, and this is what they say. Go into the ED there. Or even, you know, it's just my usual heartburn. I promise y'all. That's what it is. And then we run a step 12 lead. You got a stimmy about this high. And the wife is over there in the corner going, told you so. That's the last thing he needs to hear at that point. And then the cardiologist comes in, and guess what the cardiologist says? Sir, I have you scheduled for a quadruple bypass this afternoon. You see where I'm going with that story. So never, ever undermine chest pain, ever, because it could be the deal right there. So anyway, when in doubt, check it out, use this. And before we get going, you see this? This is the shock model. Y'all are gonna know this. Usually I write this on the board in a big square with the cardiac, you know, big heart. There's a lot of different kinds of shock, right? And, you know, like cardiogenic, we have neurogenic, we have anaphylactic, we have septic shock, we have all these. But guess what? You know how easy shock is? It all leads to what? A decrease in cardiac output. Can you cause them to have a decrease in cardiac output if you give them too many antihypertensive meds? You bet you can. Or even bradycardia, like a beta blocker. You can cause them to go into cardiogenic shock. So this is going to be part of our deal. You're going to see this every single class. There's a lot of things that's going to cause a decrease in cardiac output, CO, which leads to a word called hypoperfusion. We're going to get to this today with IV fluids and stuff. And then hypoperfusion actually defines shock. That's what shock is. Now this is the literary part, like, oh, I'm shocked. No, shock is a physiological thing. It really is widespread hypoperfusion to it. Do you need perfusion to your tissues for your toes to live, for your fingers? Yeah, but especially organs. What if you don't treat them properly? then the organs start to die. It's called multi-organ, dysfunction syndrome. Well, it's right there. You guys are gonna be shock experts, absolutely. Okay, are we ready for some content? What time do we have? Okay.